I can tell you guys. I'm moving towards administration. I have an MBA also, so I'm just trying to see if I can learn something about healthcare policies. So that's my goal from this program. This is my first class actually in this master's.
Awesome. Courtney?
Hey guys, my name's Courtney Bro. I'm from Medley, Louisiana. I've been a nurse for 13 years at Children's Hospital down here, and this is my third course. And my end goal is to just use this degree to become a manager or director of a unit one day. Hopefully the unit I'm on right now, which is a short stay surgical unit. And then I'm a single mom of a little girl. She's 10, so she's pretty good about following directions. But if you happen to see me turn my head or shush, don't take it personal. I think it's you. It's usually my daughter.
Joy?
Hello, my name is Joy. I live in Eau Claire, Michigan. I've been a clinical laboratory scientist for 15 years, and I'm trying to get into administration.
Okay. Shannon? Is Shannon still having a hard time? Shannon, I unmuted myself, but I still don't hear anything. I'm going to ask her to introduce. You want to introduce yourself over I am. Okay. We'll check back in with her. Tanisha?
Hi, my name is Tanisha. I am a respiratory therapist. I have been a respiratory therapist for 16 years at Children's Hospital. I live in Arkansas, in Mayflower, which is a little town right outside of Little Rock, our main city, our capital city. I have a little girl. She's 10 years old as well. So you'll probably hear her playing music in the background. And my end goal with this program is to get into administration within our department. Yep.
Awesome. All right. Well, while we're waiting on Shannon, Lindsay Turpin from Ohio. I am currently a senior consultant for Deloitte Consulting. I've been in healthcare provider for 10 years, primarily working with supply chain executives and CFOs on helping organizations save money in their supply chain.
Wonderful.
Awesome.
All right. So now that we kind of got introductions out of the way, just from a logistics standpoint, I think we're going to have like team stuff going on all the time. I exited out, but let me get back into Moodle and then also to my email. I think can we establish a time weekly that we are able to get together, even if we don't spend a whole hour together, but maybe some weeks will be like 30 minutes or so that we just get together and make sure everybody's good to go and everybody's on the same page with what we're doing.
Right. Yeah.
Does Wednesday nights work for everyone, or?
I mean, for me, Wednesday nights would be good, and I think it's a fairly good day if it can work for others just because it's in the middle. You know, it gives us time to work on some stuff the first couple of days, and then everybody get together, share ideas, share research, and then have enough time to finish up the assignment.
It's good with me, too.
Yeah. Wednesdays nights work for me. I do a rotating schedule, so some Wednesdays I'll be off all day, and other Wednesdays I won't be able to join until like this time.
Okay.
We can keep the same time actually every week, so.
Yeah, I'm good with that too. I think the evening time at this time's fine if it works for everybody else.
Well,
That works for me.
Allison,
it doesn't work for me. If you guys, I'm in Michigan, so it's like 9:30 here. So when I get home, it's around 9 o'clock. So if we could do 9:30, 8:30 your time, that would work better for me where I can get on.
Okay.
okay. So it sounds like, Allison, what about you?
I'm fine with that. It's 8 or 8:30 on Wednesdays is good with me. Whatever works best.
Okay. So
9:30 works for me.
and that's Chris. Oh my gosh, Christy, I'm so sorry.
You're fine. I wasn't gonna say anything.
Oh my God, please introduce yourself. I'm so sorry.
Okay, my name is Christy. I live in Orlando, Florida. I just graduated with my bachelor's from University of Central Florida a year and a half ago. And ultimately, my goal with this program is to get into health administration.
Okay. So sorry. And you said Wednesdays does work for you?
Yeah, that's fine. Wednesday evenings, except for this coming Wednesday, I'll be in DC.
Yes, bring me a pen.
Okay. No problem. So Tanisha, Wednesdays works for me as well. Let me get back to the Skype meeting and see if, okay. So Shannon lives in Georgia, and this is her 4th course, and Wednesdays are good for her. So Shannon, you can hear us? I'm working on the computer. Okay. Okay, so let's plan on then, let's plan on Wednesday at 8:30 Central Time, 9:30 Eastern Time. Does that work for everyone?
Yes.
Works for me.
Yes, that works for me.
Awesome. Okay. All right, so let's talk about, okay, Amin, thank you for taking care of that. Let's talk about our assignment then. So the first part of our assignment, and I think everybody read the assignment, checked in. I know we had a couple of questions around one of our team members, Armin, had had offered up Medicare expansion as a choice. And so, and then a couple of other people weren't sure if that, what we should do, because it looks like other teams might be doing that as well. So this is the goal for this assignment that's due on Sunday. So the goal for this assignment is for your team to identify and agree on a healthcare policy problem that you will work during the term. Your problem must be state-based. If your team is not composed of participants from a single state, choose which state you will be using for your project. It must be a state that at least one of your team members resides in, which I think we're fine. We've got multiple states covered. So our assigned team number, that's 13. So I'm just going to copy this quickly and put that over here. Okay, make this a little bigger. Okay, so our team number is team 13. So team number, we're team 13. Okay, team name. Anybody have any ideas on a team name?
Ocean's 13.
Say that again, Amin.
Ocean's 13. Ocean's 11.
Ocean's 13.
Ocean's 13? Is that what I heard?
Yes.
Okay. Anybody against the name Ocean's 13?
No.
All right.
I'm not.
let's go with Ocean 13 unless anyone has any issues. And then as far as, Christy had started putting this together for us because we thought we were going to go with the Medicare expansion. So this is what she had put together for us since she's leaving to go to D.C. So Louisiana Medicaid expansion, Louisiana residents who are at the 138th% of the federal poverty level. So my question is, maybe we just go around quickly and see if anybody is opposed to doing Medicaid expansion, and if we want to do something else. And,
Well, I mean, I appreciate the work they put in, but my only concern was just because, like I said, other teams, it may sound juvenile, but other teams were already doing that. And I just wanted us to have something that was a little different, had a little impact, and made us stand out as a team. So that's why I had sent the message earlier, and I like the ideas that Ricky had presented. But I don't also want to downplay the work people have already put into it. So, anybody else have any ideas or any feelings about it?
And I think the Medicaid expansion is a very broad topic, because if you look at the questions there, these 4 things which we would have to define later on, who's affected and how many are affected, is what are we hoping, what's our solution to the Medicaid expansion? That the state lowers or increases the bar, what people make? Because you have to set that bar at some point. There will always be people who make a little bit more money than that.
Yeah.
So, I think it's a very broad topic, and we may not find adequate research on it.
Yeah.
I agree with the two of you as well. I think maybe picking something that's a little bit more tuned into something specific, and just remembering that we have to stick with this for the next 7 weeks. So it should be something that we're, all interested in. And
we should pick a simple problem, which is a little bit easier to fix, a little easier to explain.
Right. I think we'd be burning ourselves out with this particular topic with, like you said, the broad aspect of it.
So, if you'll go back to what happened to Ricky, he's not, he couldn't join.
Ricky was having trouble signing in, and I texted him, and he didn't respond.
Okay. All right, so I'm just gonna look for his post here, so the things he has suggested, if I can find those.
yeah, and I have it up on the screen too. Can you all see that?
Okay.
Oh, okay, yeah, I see.
So he offered pharmacists attaining provider status, health insurance for elected officials, policies regarding opioid prescribing, and then mental illness.
Right.
Right. If so.
On pharmacists attaining provider status, and since we have a pharmacist in our group, that's not something that is state specific, is it, Allison?
It actually, I think it actually is. I think that there may be some states that have gotten to provider status. I can look up real quick.
And I think the mental health one, that's really broad as well.
Wellness, you said?
The mental health, I'm sorry, I can't see the information that you presented. My screen is black. I can see everybody's faces, but I don't see anything that you're presenting. But the mental health, that's really broad too. So what specifically would we be looking at?
So would you guys be interested in working on the rising cost of prescription medications, which is quite simple to fix actually, and it's a major problem?
I think that's a good idea, but kind of the same question. Do you think we can make that state specific?
No, it's not state specific because you mean the price for the medications?
Yeah.
Right. I think the topic needs to be something that we can, pin down by a state specific thing. I like the idea.
It wasn't a part of this list, but something that is state specific or just an idea, even if it gets us brainstorming, is the physician euthanasia versus like physician assisted suicides, patient rights. Because, Louisiana, I think it was, when I looked it up, Washington State, I know, is one where it's legal. And they had that story of the woman who had cancer. And she had to move from her home state to Washington so she could die with dignity. And then I think it was the Netherlands and Luxembourg were the only other places.
So I did just look up, kind of going back for a second, the provider status for pharmacists is a state specific. So there are some states that have provider status for pharmacists and some that do not.
Provider status for pharmacists, all right.
If we went back to the pricing thing as a suggestion to make it state specific, could we tie that in with Medicaid some kind of way, and pricing with Medicaid?
It is actually, it's kind of with Medicare and all the insurance actually, because it doesn't matter what state are you in, it's the same problem. So what Medicare is same across the country.
Right.
So basically the problem is right now there is no cap on the drug price the insurance company is charging.
Okay.
So Medicare or the commercial insurance or Medicaid, they will pay a certain portion of the drug and then patient is responsible for the rest of it.
Right.
So to give an example, so we have a big problem with the insulin right now. So insulin price has gone up tremendously, so people can afford it because the copay has gone up. So, for example, if insulin was costing $100 before, so Medicare was paying 20% was patient's responsibility. So now the same thing is about $1,000. So that copay has gone up to $200 from $20. So there's no cap on the price of the drug. So that's one problem which is relatively easy to fix with some sort of healthcare policy to cap the price on the drug.
Okay. So it sounds like we have a couple of ideas. One being the pharmacist base to provider status, and then the cost of drugs, and then also the Medicaid expansion. And I think we've kind of kicked out the Medicaid expansion due to other groups doing it and being too broad. So do we want to take a vote on the pharmacists attaining provider status or the cost of drugs?
Sure. Does anybody else have any ideas?
I have a kind of idea.
Okay.
So in a lot of states, you don't need a prescription to get insulin syringes, but a lot of drug users try to get them. But it is ultimately up to the pharmacist upon their discretion whether they want to give it to the person or not. But usually, because I used to work as a pharmacy technician, so usually if we couldn't obtain proof of prescription, we wouldn't give it to them, even though technically a prescription is not required. But that also begs the question with people not having access to clean syringes, you can spread disease that way. And, hepatitis and a lot of other diseases are very prevalent among, drug users. I don't know if that's a good topic, but I just thought I'd throw that out there.
Yeah,
Most of the state actually, they provide insulin without a prescription. So the difference is there are some states which do require a prescription, but every state, if you have a prescription, insurance pays for the insulin syringes. And most of the states have some sort of program for the people with intravenous drug use. They can go get clean needles. It's most of people that don't utilize it, but most of the counties and states have that kind of program.
So is it state specific with you? Does your state provide it or not provide the clean needles for or the insulin needles for patients? They have to make sure that they have a prescription before they'll give them the insulin needle.
Tanisha, you're asking me. Sorry, my connection is not the greatest.
It's not required to have a prescription, but it's up to the pharmacist.
Oh.
It's up to their discretion whether they, want to give it to them or not. But in a lot of states, they do have restrictions, age restrictions, and I think some do require a prescription.
Okay. Taylor, go take a bath, baby.
Christy, what are you suggesting? What should we work on about the syringes, just to make it available across the board without any discretion from the pharmacist?
I mean, it could go either way. I don't know. I just thought maybe there definitely needs to be some type of revision, whether it be, healthcare policy based on, just, I don't know.
I mean, then it has to be like a broader healthcare policy addressing the intravenous drug use, actually. Then you can tie up your syringes in there.
Mm-hmm.
It's by itself, it's a very small thing to put out.
Can anyone hear me?
Yeah, we can hear you.
Well, I'm here.
One thing, if I hear you right, then you are working on lines like how to decrease bloodborne or person-to-person or bloodborne diseases in patients or people who use intravenous drugs. So that's something we can look into. In addition to needles, what can you offer them? So we can see what the current policies are, if there are any, which I don't think there is any recommendations from the government. Most of the things are at state level. The government, I mean federal government.
Maybe we could look at, going on with this topic, if we're going to do it, we could look at, based on different states, what their bloodborne disease, what the percentage of people in their population that have it. And then we can look at another state that has a lot more restrictions on access to needles and see how it compares and what their policies are on the state that does not have a lot of bloodborne disease percentage.
So we would have to look at the hepatitis C and HIV incidence, new conversions statewide. All the Department of Health in every state track the data. Hepatitis B is also there, but it's usually less commonly transmitted. So, what state you want to look at, and then compare?
I don't know. It would definitely, this topic, I feel like, require a little bit more research, just kind of comparing the states. But I mean, we could definitely easily pull up the state with the highest percentage and the state with the lowest percentage, and kind of compare policies and kind of say, you know, maybe the state with the highest needs to restrict their policy, and kind of revise it compared to a state that does not have as many bloodborne diseases.
What we could do if we were gonna, look at this topic, because it has to, the state that we choose has to have a member from that state. We could take, the combination of our group member states and kind of look at what their current laws are and how strict the dispensing rules are for syringes, and then from that go in and look at those bloodborne disease rates.
Allison, you're the one that's a pharmacist, right?
Yes.
So do you work retail or?
Yes.
So in your pharmacy, what are your policies?
It's just as you were saying, it's up to the pharmacist's discretion, and it's mostly accompanied by a medication that would require syringes. So I